Thank you. I think it's a combination of a few different things. First of all, as most of us know, cesarean delivery is the most common inpatient procedure that occurs worldwide. And when we look at the administration of anesthesia, the primary goal is to deliver it via a spinal or epidural anesthesia. That provides the most minimal risk to the mother and to the fetus as well. Unfortunately, approximately 15 to 17% of the spinals and epidurals will fail at some point during the cesarean delivery. And to your point, it's kind of a combination with it. The part of it is the technical aspect. A patient's habitus can affect the success of the placement. A patient with a high BMI makes it challenging for the anesthesia provider to be successful in placing that spinal or epidural midline, which we know midline is the optimal place for the location for the medicine to go into. Also, some other technical challenges that can happen can be if there's abnormal spinal anatomy. So, if the patient, for instance, has scoliosis, the other things, or if they have had like spine surgery in the past, that can interfere with not only the technical difficulty of placing it, but also in how the medication distributes. So, a patient who has a curved spine or who may have some type of foreign object in the spine can affect how the medication may flow. So therefore, the patient may end up with areas that may not be numb or even a whole side that may not be numb. The other thing that plays into it is a patient's history of pain. So if they're a chronic pain patient or if they have substance use disorder where they may be addicted to opioids, that affects their ability to tolerate pain. They have a very low pain tolerance, and it often takes a lot more medication and actually a multifaceted approach when trying to provide those patients analgesia. The other thing is if the patient just has a high anxiety disposition, those patients with high anxiety tend to have also higher incidences of pain from the surgical procedure, and a lot of times these things can't be prevented. There can be things that happen in the surgery that can extend the surgery. So, for instance, there may be excessive blood loss. The patient may have had a prior cesarean delivery or a prior abdominal surgery, which makes it more technically difficult for the surgeon. The patient the fetus may be in the wrong position, and so it extends the surgery procedure. Other things that can happen is the surgeon may need to actually exteriorize or remove the uterus, and that is usually more pain inflicting when that happens. If the patient develops an infection in the uterus, which is called chorioamnionitis, so the fluid that surrounds the baby can sometimes become infected. And so that is actually because of the infection, it changes the pH of the environment. And that change in pH actually affects the local anesthetics. So the local anesthetics, when there's an infection in place, may not work as well. It can be that the patient may be in labor and we have a labor epidural that we're using for that patient, and it may be providing adequate pain for labor. But when we go for cesarean delivery, the epidural may not function well enough for the surgical procedure. And that can be multifaceted as well. A lot of times, if an epidural's been in for a long time, that catheter can deviate off midline, which then makes the medication not flow as well. The other thing is our epidural catheters have multiple orifices. And if a catheter has been in for a long time, some of those holes will actually occlude because the tissue will start to occlude those holes. And therefore, again, if you don't have all the holes open, that can cause inadequate dispersion of that medication with it. So, also, I think the patient's understanding coming into the procedure of what they may experience. And that's really important for the anesthesia provider to explain that. The patient will feel things. It won't be that they won't sense anything. They will sense movement, they will sense some tugging, they may sense some pulling, they may sense some pressure. However, it shouldn't be uncomfortable. That's the message that the anesthesia provider needs to give to the patient. But sometimes patients think that they're not going to experience any sensation, and that is not realistic. So it's making sure that communication and understanding is there.